Hello everyone, you're extremely welcome to our second webinar entitled Nursing and Midwifery Clinical Leadership During COVID-19, Sharing the Learning from Older Person Services. I'm absolutely delighted to welcome our expert panel this evening. Our panel is Deirdre Lang, who is the Director of Nursing, National Lead, Older Person Services, Clinical and Integrated Programmes, Office of the Nursing and Midwifery Services Director. Our second panellist is Brian Mcguinness, who is a registered advanced nurse practitioner in the Mater Misericordia University Hospital. Brian is a registered ANP in Older Person Services. And I'd like to finally introduce Clare Noonan, who is a registered advanced nurse practitioner in gerontology in Tallaght University Hospital. You're all extremely welcome here today, and I'm delighted that I've had the opportunity to meet with you and that you'll be able to present on this webinar. So without further ado, we're going to start with Deirdre Lang. Deirdre, again, you're very welcome. Deirdre, as we spoke earlier on and we've engaged over the last couple of weeks in relation to preparing for the webinar, it is obvious that COVID-19 had a significant impact on older person services, from media and from talking to colleagues and from talking to people who've had family in residential care. I suppose, Deirdre, you have a national role, and I suppose we're privileged in national roles to have that ability to have a helicopter viewpoint of what's happening nationally. And I'm really interested, and I'm sure our listeners would really like to hear today, you know, in your key position, you've had an opportunity to see what's been happening in different areas, from working in services, from collaborating with colleagues. Could you talk to us about the lived experiences of your colleagues in older person services over the last 6 months?
Thanks, Marie, and thanks for the opportunity to do this. I suppose in order to answer your question, I need to give you a sense of the background to put a context to the COVID situation in residential care for older people. In Ireland, we have 526 registered residential care facilities in the country, and they provide care to 32,000 people. That's mothers, fathers, sisters, brothers, aunts and uncles. 80% of this care is provided in the private sector. It's a nurse-led sector, and it has support from the multidisciplinary team in the public sector, but less so in the private sector. A medical officer provides clinical governance in the public sector, but a number of GPs attend in the private facilities, and you could have as many as 12 GPs attending individual groups of patients, but they only provide care to their own patients. Nurses working in residential care are experts in the care of the older adult, or gerontological care. They're experienced in outbreaks with flu and norovirus, and they're very experienced in end-of-life care. However, COVID, as we know, pushed this sector to its limits. 22% of all cases of COVID, that is 5,608 older people, experienced COVID by the end of June. And sadly, 971 of those people died, which represents 56% of all the deaths from COVID at that time. The complexity of the situation was increased for the sector as older people didn't present in the way the World Health Organization symptom list suggested they would. And while the sector did all it could to prevent the virus coming into their homes, we didn't understand the potential for asymptomatic spread. Access to supports, particularly geriatricians and advanced nurse practitioners, were crucial. And you're going to hear from Clare and Brian as to how their innovative approaches impacted positively.
Deirdre, I'm just very aware of, from your own role, that you supported during time. It was part of your role, but I know that you were heavily involved with supporting our colleagues in older person services with developing initiatives and responding to COVID-19. Would you like to tell us about some of your own work in this area and what you were doing to support services?
So as is always, gerontological nurses step up to the mark every time, and we set up an advisory group of gerontological nurses that helped us to work on clinical documentation to support our colleagues who are working in practice. We also set up a WhatsApp group Well, in fact, it ended up being 2 WhatsApp groups, because who knew that you could only have 275 people on a WhatsApp group? Anyway, we ended up with 500 members on our 2 WhatsApp groups. And the reason we set that up was to provide peer support, to provide real-time answers to queries for health professionals who are managing in a pandemic, to give them updates from the HSE, to allow us to sense check how services are managing, and to assist people to reduce their stress, because they're working a lot in isolation.
And Deirdre, it's really good to hear what was happening from your perspective and your role. And I'm wondering, and I know people would like to hear from your perspective and from your experience in your role, what was the response like, and what did you see in older person services? COVID came in March. From the statistics you presented, it had a significant impact. And in some ways it's quite heartbreaking listening to those figures. Can you talk to us about your experience and of what happened and how older person services responded to COVID-19?
I've asked my colleagues to share that with me, and really I suppose what comes across is the psychological impact for staff caring for residents who were dying without family being present, and the number of deaths that happened together was quite significant. These are people who are used to end-of-life care, but it really hit them hard. The overall level of upset suffered by staff, relatives and residents connected with nursing homes can't be overstated, Marie. When COVID got into a facility, it seemed to spread with undue haste. One facility reported 3 residents had died within a single 12-hour period, and then they had another 3 deaths within 48 hours.
Deirdre, as you're speaking there, I'm just interested to know, and I'd like to know, how are the staff? How are they doing now? Because it's been such a difficult 6 months for them.
There's been a significant number of staff who've contacted COVID-19, and that placed an unmerciful strain on the maintenance of basic staffing levels. The national advice changed daily, and for those in charge, provided with new updates which were overwhelming. The amount of information they got was overwhelming, and trying to maintain their credibility when the national advice was changing daily was very difficult. Maintaining the trust of their team with this ever-changing message was crucial. But it was down to the leadership they demonstrated. Each and every one of them who took charge demonstrated supreme leadership. They needed to have a low level of suspicion of any change in their residents, and they needed to trust their clinical expertise when seeing something that was a change. That was crucial, because things like delirium and falls are key indicators in this cohort of people, but that wasn't taken into account initially. And those things are particularly made worse when someone is speaking with a mask, or when that poor person has to be isolated. There's a need for people to understand that residential care in gerontology is a specialism, and that it's not just anybody can attend. It's like any other specialist area. It's not just anybody can work there. I'd like to mention particularly the sacrifices made by many of them. Many people didn't see their families. I have one example of a nurse who hadn't seen her own 7-year-old daughter for 6 weeks because she was trying to keep her residents safe. People missed birthday parties, they missed weekends, they gave up their time. Some people worked 3 months continually without a day off. But key to the response, Marie, was the HSE COVID-19 response team. That was crucial. Speedy access to PPE was imperative. Staff levels were overstretched due to illness and the need to isolate. And this is something that still causes many of the staff concerned, but they're distressed, and the sense of guilt they felt with not being able to attend the residents and not being able to support their colleagues. We need to look at that going forward.
It's obvious, Deirdre, it's been a really, really challenging time for staff, and they have really gone, beyond the call of duty, as have many other disciplines as well. But I think we particularly heard about older person services in the last few months. And out of COVID-19, as we know, the expert review group, in terms of the expert review report on nursing homes, I just want to ask you about this, because from reading it, it looks like it's a really good review, and I know there's so many recommendations. I think there's nearly 90 recommendations in it, and just from speaking to colleagues in older person services, it certainly is welcomed. From your role, Deirdre, with your experience in this specialty, What is your own perspective on the expert review of the nursing homes that has come out in August?
So Marie, you're right, there's actually 86 key recommendations and it is a very welcome report. In the interest of time, I'd suggest people read it for themselves. It is a wonderful read, it's very positive. A few of the things that particularly excite my future older self are the new model of care. So future models of residential care, it suggests, should include outreach support from hospitals and in-reach support from communities. While there should be a focus on empowering the older person to remain at home, which is good for us all to know, but where residential care is required, they're suggesting innovative models, including smaller domestic style units which are integrated into towns, communities and cities. That's really exciting. The IPC lead education and accountability, and they talk about proactive planning and preparedness. The GP role governance, so I spoke to you about that before, and they're looking at key GP role governance for every residential care setting. Keeping the community response teams uplifted, which is very, very important to ensure support going forward. And staffing. I've been informed that phase 3 of the staffing framework literature review is already being undertaken by Professor Jonathan Drennan. So that is something we've talked about for years, and we're really excited to hear that. And finally, I suppose the piece that excites me most is that education in gerontology is imperative, and it's recognised that gerontology is a science and an art.
And obviously, from your perspective, you welcome the review, Deirdre, and from the key points you've raised, there is very positive aspects to it. And I suppose all we can hope is that the recommendations are implemented as soon as possible. Just in relation to your own role again, Deirdre, I know there's many aspects to your role, but one of the aspects that's key is your advocacy role for your colleagues working in older persons services nationally. And I suppose we just have seen a lot of different, things going on in older person services over the last 6 months. And a lot of them have been incredibly positive. And just from speaking to you and from speaking to the panel and from colleagues, there has been really good initiatives. And I think this is a really good opportunity to have our national lead share those positive aspects on behalf of your colleagues and to advocate, because we do need to hear the really good news stories as well that are so prevalent in older person services. So could you tell us about some of the initiatives that you've seen in your role over the last 6 months?
So the IT support, I suppose, is phenomenal, and we really are moving into that new world. Attend Anywhere is going to be available for all residential settings, private and public, to allow for virtual ward rounds to ensure the support of the MDT and GPs if there's ever an outbreak again, or for ongoing care. IT support that the residential care facilities themselves used to facilitate interaction for residents and exercise classes, that's something we need to hold on to. And it was them using creativity that ensured their residents got that. The IPC leads and the daily reviews, including the buddy systems and the toolbox sessions that people introduced to ensure that they maintained the highest level of infection control. Test and trace, that's crucial, especially with the asymptomatic transmission rates. And colleagues must be commended for adapting to this new world for their residents, often coming in on their days off to attend for their own testing. Marie, residential care is by its very nature congregated settings, and those who reside there are frail. By that very nature, they've very little reserve, but they're in their last 1,000 days for the most part, their last 1,000 days of life. And that must be balanced with effective risk assessment and the person's preferences. Those who work in these settings are experts of person-centred care, and they make decisions on behalf of their residents that reflect their residents' wishes. We must remember those we have lost: mothers, fathers, sisters, brothers, aunts, uncles, and residents. And also consider all that has been achieved in such a short period of time. We must, as a nation, thank those who have given so much to care for their residents during this critical time and given so much of themselves.
Thank you, Deirdre. I think that's a really positive message to give to our listeners and to anyone working in this sector. I'm going to move on now to Brian Mcguinness. Brian, as I said, is a NORI MP in the Mater Hospital and Older Person Services. And I suppose just to set the context, Brian, could you tell us a little bit about your role prior to COVID-19, briefly, if you don't mind? Thank you.
Hi, Marie. Thanks for the opportunity again to speak. I commenced as an A&P candidate as part of the Department of Health demonstrator project back in October 2017. And in care of the older person, I was mainly based in the daycare unit for the older person in the matter. And my main focus is dementia, Parkinson's disease, and movement disorders. So that's what I've been doing up until COVID hit.
Okay, Brian, and then March 2020 and things changed dramatically. I know that you're going to present really on the establishment of virtual clinics for older persons, which has been key in supporting your patients over the last few months. Could you talk us through what led you to decide to do this and give us a little bit of the background to it, please?
Yeah, absolutely. When COVID-19 hit and the lockdown happened, we had clinics 5 days a week, and some of them are specialty clinics, and all these were postponed. So we had to really think differently. I really felt strongly that we couldn't neglect usual care. Chronic disease management is vital for our elderly population, especially those with dementia and Parkinson's and movement disorders. So we set up a virtual telephone clinic for these patients. So the day that they were due in, they would get a telephone assessment instead of a face-to-face. It took a bit of planning, and it took a bit of trying to get to know the system and how the whole virtual thing works, but we were able to manage it. And what we did, and how I'll describe the process really, is from a three-point view: the pre-encounter, or the pre-telephone call, the telephone call itself, and then what the post-encounter. So those three things were vital to be able to have that all-round episode of care completed. The big things from a pre-encounter point of view was the prep, was the patient being called and make sure they're available to take a telephone call, and even having their carer or relative there available with them. We found that 47% of the time we actually spoke to the relative of the patient. That was due to either their condition being of dementia or because of hearing loss and various different things. So we had to get the results of maybe previous investigations that they had, some letters of correspondence, to read through the chart and be familiar, so we could actually talk to the patient and be able to fulfill that good quality assessment over the phone. From the telephone call itself, we found the best way for our elderly population was through their landline rather than their mobile or a video call. A lot of our elderly patients didn't really, and dementia patients didn't really grab the concept of video, and their landline is so familiar to them. That's what we found really worked best. The technique during the call, again, common sense, maybe keeping a calm persona, introducing yourself. We used a performer, which really helped to structure the assessment on the telephone call. From being a clinical nurse specialist, I would have had a telephone service over many years, so I was well used to it. One of the NCHDs, one of the SHOs who was helping me, or we both worked together on this, she wouldn't have necessarily had great experience, so she found the performer really helped that way. I suppose as an A&P and bringing in my background, I had that higher level of clinical decision making, so that really helped during the telephone call as well. It was a great opportunity to provide education about the condition, support and advice, and other things that we found when we identified a problem from the performer. The post encounter, then, it was really important to be able to document our conversation and our telephone call, follow up with prescriptions if we made or recommended medication changes, order tests, onward referral to the MDT, or a further referral through to, say, rheumatology if they were having trouble with pain in their joints, and then to reschedule another appointment.
So even though it sounded like a simple initiative, Brian, there was an awful lot to it. And I suppose in terms of presenting the process, you really had to include very clear communication with your colleagues and have the process very clearly outlined so that it did work really well. And I suppose I'd just really like to hear about the outcomes from the process. Could you talk us through some of those?
Yeah, so between the 12th of March and the end of the lockdown on the 30th of June, we actually did 713 telephone assessments, and 48% of these patients had dementia. So that's why we had to spend a lot of time talking to the relatives, and sometimes we spoke to both the patient and the relative. Some of the other outcomes, when we identified a problem, it made up as 60% of patients had a problem identified. And the big top four was deterioration in memory, was an increase in their pain, a decrease in their mobility, and an increase in their bladder issues. And we could see a trend as the months went on between March, April, May, and June, that these increased. So that was important to be able to recognize these things, even for future lockdowns or future virtual clinics, if they are taken on by other people, that there was a definite trend in those four things. But I felt that the virtual clinic was well able to manage an episode of care. And that meant, you know, we had 65 patients that we were able to onward refer to a GP, for instance. Nearly all our patients got some sort of advice or support, even if it was around the lockdown, or even it was around precautions with COVID-19, or even about how to handle somebody if they're getting more agitated, or you know, increasing anxiety from their dementia point of view. It really helped to be able to have that opportunity during the call as well. And then we had to, unfortunately, refer 2 patients to the Actions in Emergency because we picked up that they had COVID just from our assessment, and one lady unfortunately passed away. But it was a good opportunity. At least we were there to help and be a support and identify these things during the call.
So there was a lot of really good outcomes from the processes that you implemented yourself and your colleagues, Brian. I'm sure it wasn't easy, and I'm sure there was challenges during that time. And it would be good for our listeners who may be considering and maybe at a place where they're thinking, okay, I could set something like this up in my own service. What were the challenges that you encountered? And maybe if you could include some of the enablers as well, it would be beneficial.
Okay. I suppose the virtual clinic doesn't fully replace the face-to-face assessment for the patient. So when I came up with the idea or tried to implement it, I was met with skepticism, and people's perception of a virtual clinic varies. Some people think it's just a chat on the telephone, you know, that you're just ringing the person to see how they are. And I was very much coming from the aspect that this is an assessment and a clinic appointment that's over the phone rather than face to face. So the acceptability of a virtual telephone clinic takes a bit of time, and you know, I worked hard to get that buy-in, both from colleagues and senior management within the hospital as well. Our patient cohort, one of the challenges was the limitations from their point of view, their hearing loss and their dementia and their understanding. So that was a bit of a challenge. The time factor, again, if we were ringing both the patient and if their carer or relative was on, you know, in a different place, we'd have to make 2 telephone calls. And then just access to the minimum requirements was, you know, a telephone. We couldn't examine them. We couldn't do a cognitive assessment. So there were limitations. So again, that was a challenge. But I'd say the biggest one was the whole perception and the skepticism around it. The enablers, I suppose the family and the patients were fantastic. They really took this on board. They really felt safe in their own home, and they felt comfortable about having a telephone call and knowing that they didn't have to put themselves at risk coming in. Being an AMP as well was a really good advantage, having that higher level of clinical decision making, that I felt really comfortable being able to manage the virtual clinic and the virtual call. A lot of research has been done even throughout the COVID period, especially in the Netherlands, and they've looked at these type of things, the advantages of having a virtual clinic. And some of the things that's coming out is that they're calling it the 5 C's, that there's reduced contagion, the patient isn't being exposed to infection, that there's an expanded care, we're able to do more things for the patient, even though we can't see them in front of us. There's increased convenience for the person. There's enhanced comfort, and there's greater confidentiality, that it's just me and them on the phone. There's no one else that's able to interrupt or hear. So that's really kind of backing up and creating a good buy-in for going forward for other people to be able to manage these and set up these virtual calls.
And I suppose from your presentation of the actual process, the outcomes, and even in presenting the evidence, Brian, that supports what you're actually doing from clinical outcome perspective, It's really, really reassuring to hear that. What I'm just wondering about, because in recent years, thankfully, we're really putting the patient and the family at the centre. And as we know, it's nothing about me without me. So I'm just wondering, I know it was difficult at times you were dealing with caregivers because of maybe deficits such as hearing loss or dementia. With your cohort of patients and their caregivers, did you ask them for feedback on their experience with virtual clinics?
We did. Feedback was very, very positive. We've since got emails and letters and cards just by way of thanks for the call. Patients and their relatives really appreciated that we took the time to call them, that we just didn't abandon their care. They felt that their care continued during even the COVID period that caused an awful lot of anxiety for the patients. I was one of the team that set up a committee for establishing a hospital policy and procedure for virtual clinics. And as part of that, one of the innovator managers, she did a telephone survey with some patients that we had done earlier on in the virtual clinics. And again, she received very good positive feedback for the patients of, again, like the things they found in the Netherlands, the convenience of it, the comfort of it, not having to leave the house a few hours before the clinic and, booking taxis and the journey and the stress, that they could be managed in the comfort of their own living room. And that, for frail elderly, that makes a huge, huge difference to them. It may not seem to be a thing we'd think about, or even the hospital management might think about, but it's really important for those patients that they have that comfort there and they're not distressed by having that journey. I suppose the big thing is having that combination going forward, that the patient still has the choice to come in, and we can alternate it with having a virtual clinic every second visit, is something that we could really look at. And the patients have suggested that we still like to see you, so could we have a visit every second one? But they really like the idea of having the virtual clinic as well.
And it's really great, Brian, that you've offered them that flexibility and that you're really hearing where they're coming from. And the inclusion of their feedback on this initiative is excellent, because I think it's been really challenging for patients, obviously, as well. And just to meet their needs, it sounds like you're doing everything you absolutely can. So well done on that. And I suppose my final question to you, Brian, is, with anything like a pandemic, our responses are often and have to be quite reactive. You don't have the time to be putting a lot of thought into what needs to be done. And in setting up the virtual clinic, I'm just wondering, 6 months on and having had that experience behind you, for people listening who are thinking, okay, I'm actually going to do something like this in my service, what was the key learning during your journey to now for you as an RAMP, having set up this virtual clinic for your cohort of patients?
Well, the advice I would give really is to plan well. We didn't have time to plan that well. I literally just approached the individuals, the consultants, the secretaries and things. We weren't able to sit down and have a big team meeting. Our team were redeployed. The other nurses in the daycare unit were redeployed. Knowing your resources, there was myself and an SHO running this with the secretarial support, and again, looking back, we would have needed more support and more help and bodies to make the calls. Buy-in is another big thing to be able to, in establishing the virtual clinics, is getting that buy-in, getting that acceptability and overcoming the skepticism. From a practical point of view, I would say managing about 6 to 8 calls per day, 6 to 8 calls per person per day is about the limit. A call could take anything from 10 minutes to 1 hour. And by the time you do the prep and the documentation post, it does take that time frame. So I would say 6 to 8 would be the limit per person. The management of the call is, having a good telephone manner, being able to get the trust of the patient. You can't read their body language. You can hear their voice over the phone. So you really have to kind of be calm and identify yourself well and explain who you are and what the call is about. I had the advantage of knowing most of the patients from the daycare unit, but that's where the SHO kind of found that she really had to spend a little bit of time explaining who she was and what the call was about. And using the performer was paramount, I think, to give that call a structure, to be able to go through all the care needs, their sleep, their mood, you know, bladder issues, their medications, if they've had falls, their mobility, all those things are really important to capture to get that full episode of care. And then drawing up a policy if that's feasible, and that is actually the foundation is there and the structure that there's a quality among, you know, when a virtual call is going to be done, that is the same across the board. It might differ for different specialities, but definitely for our specialty like dementia and Parkinson's patients, it's really paramount that they have a choice and it's done well.
Brian, thank you. I think that guidance is very clear, and we're all going to benefit from your journey since you set up the virtual clinic, and it's a wonderful initiative. So thank you so much for presenting on it today. I'm going to move on to our next panellist, Clare Noonan. And Clare, as I said, is an RAMP in gerontology in Tallaght University Hospital. Clare, you're very welcome. And I'm going to start with the same question as I started with Brian. I suppose it's just again to set the context. Could you tell us a little bit about your role as an RAMP in Tallaght University Hospital?
Hi Marie, thank you so much, and I'm so delighted to be part of this webinar. Well, as a teaching hospital, we're always looking to learn and improve the care that we provide for our patients. So as part of that, one of my mentors, Professor Sean Kennelly, did a study in the past that looked at the level of nursing home emergency department admissions over a 12-month period. In response to that, my role was actually developed within CHO7, liaising with the nursing homes and residential care settings in Dublin West, South, Kildare and Wicklow. So we cover about 12 nursing homes in CHO7, along with the orthopaedic admissions that bypass NACE and come straight to us. So we're looking at about 1,100 beds altogether. Like Brian, I was part of the demonstrator site in 2017, feels like ages ago, and the service itself was developed in 2018 as part of my candidate journey. I worked together with my mentors and the consultant geriatricians here within Tallaght University Hospital, and we scoped out the role. In terms of the caseload then, we looked at all nursing home residents that were admitted to Tallaght University Hospital, regardless of whether it was medical, surgical or orthopaedic. And the service involved both the acute setting, where I would review the patient who required a specific gerontological approach to their care. And this was really to make sure that they would return to the nursing home as safely and as quickly as possible, and then followed up with a phone call post-discharge about 14 days later to see how they were getting on.
So Clare, I think the role sounds like it's a really, really good, I suppose, for integration and in line with Sláinte Care and our vision for the future, where we have these integrated roles to support both acute and bring that acute into community process. Obviously, COVID happened again, you know, as I said, in March, as we know. How did that affect your role?
Well, once COVID arrived in Ireland, we actually expanded the service to not just include the nursing homes, but to include other residential care settings. So not just older person, we had intellectual disability and the mental health service, because we realised that this was a really vulnerable group that also needed our support. I had previously really good working relationship with the nursing homes, with the nursing staff and the directors of nursing, as well as their GPs, which was really invaluable. So there was an automatic level of comfort. So when we set up our virtual video case conferences to discuss cases or plans of care, it really flowed very well. And as Deirdre said, as the guidelines were changing pretty much every day for the first couple of weeks, and as we were getting the international information, it was really important for us to keep up to date and to link in with the nursing homes daily to make sure that they were getting not getting left behind as they had outbreaks in crisis times. The last thing they had to do was to look up these new guidelines. So I pretty much rang them every day just to make sure that they had the latest guidelines available. I also had a pre-existing liaison contact number that was always Monday to Friday, so nursing homes could always ring me, which we extended. So it was Monday to Friday, then extended to 7 days a week, 24 hours a day. So really that just gave the the nursing staff a sense that they weren't on their own. If they had a problem, that we were here to support them 7 days a week. And that was myself and Professor Sean Kennelly. The role also expanded to include an SPR in geriatric medicine. And this really helped us to take over the patients as they came to hospital. So we weren't just going to review and give advice, we were actually taking over their whole care. So this really mainstreamed the communication between ourselves and the nursing home. It wasn't different people ringing all the time. People weren't getting mixed messages. Everybody knew where they were and what was happening. And also for the families. So this was an extremely difficult time for families because they hadn't seen their relatives that were in the nursing home for a long time. And then all of a sudden they were in an acute hospital. They didn't know what was happening. So they had the same person ringing them every day, which really gave them a sense that they were being looked after. So as well as updating the nursing homes, we were updating the families every day as well as to how things were going.
And Clare, you know, from presenting your role in the beginning and then telling us what you did during COVID, obviously you can see how much you actually did for older persons in the community during this time, yourself and your colleagues, and the fact that you extended the role into intellectual disabilities, mental health, and increased your service to a 7-day service. I think it's admirable, and it's fantastic to hear that. I'm sure it wasn't straightforward and it wasn't always easy. And I'd just like you to talk us through some of the challenges you might have faced whilst trying to actually offer that optimal support to your patients.
Thank you so much. At the start, there were many challenges. The biggest one being that the guidelines kept changing. But I was really lucky that I had really good relationships with nursing staff. So when I was ringing them every day, they had that sense of trust there that I had looked up the stuff and I knew what I was talking about. We had a good sense of teamwork among us. And as Deirdre said earlier on, the sheer nature of the virus and the volume of information coming at us, we found that our older people, they didn't present with the typical temperature, cough or sore throat. We were looking more at GI symptoms or just general decline. So we supported the directors of nursing and the nursing staff because they knew their residents. They knew they've been looking after these residents for so many years, for such a long time, that they were kind of part of their family. So they knew straight away when there was something wrong. So I think knowing that we were there, they didn't hesitate to call at all. And then we were able to facilitate the review in the emergency department. So that was myself and Professor Kennelly and Aoife Fallon, who was the SPR. We worked together just to make sure that the residents who needed to be in hospital were not just COVID-related illnesses, so the regular things that always happened before were still happening. So it was really important that the nursing homes knew that the hospitals weren't closed, that we were there and we would review the residents in ED. We provided a lot of support for the GPs for family discussions that were very difficult at the time because a lot of the nursing homes had to review advanced care plans and a lot of families didn't know what was happening. So for them to be able to contact us and for us to go through presentations and difficult cases was really helpful for them. Also, at the start, before the national swabbing came in, we worked with the microbiologist here in Tallaght University Hospital to facilitate staff being swabbed within the nursing homes. As the outbreaks happened, a lot of the staff, there was a lot of fear, there was a lot of absenteeism. So us being able to provide staff with quick turnaround for results was really helpful to make sure the staff were able to return to work. And then we also provided virtual monitoring systems that were donated to the hospital, to the nursing homes. A big part as well was the end-of-life care. So as Deirdre said earlier on, nurses and in nursing homes are experts in providing end-of-life care. But like that, the guidelines were changing as well for this. So we were also able to support the nursing homes that due to staffing, mainly due to staffing issues, couldn't facilitate end-of-life care within the nursing home. So we've facilitated transfer to the acute hospital so that we could take over that role. Whilst the ongoing support and communication was really challenging, it was also really, really important to both the nursing home staff, the residents, and also to their families. We could never underestimate the value of the emotional support at such a vulnerable time for the residents and for the staff. As I said, these are people who, it's not like an acute hospital where they're in and out within a couple of weeks. They become family to a lot of the directors of nursing and the nursing staff. So it was a very difficult time because due to the mortality rates, it was a very difficult time for them.
And Clare, no doubt it was just during that difficult time to have your support was key, not just for the staff, but for patients, residents, etc. You did a huge amount during that time, just from even listening to the few examples that you've given us. What would you say was your key learning, having reflected back, and even as you present now and think about what you actually did, what was your key learning from the experience?
I think the value of communication and support from and for the colleagues was just invaluable. And I suppose with winter coming upon us, we were looking at the next big challenge, which is the lethal concoction of flu and COVID and the effect that this could potentially have on our nursing home residents. But now we have much stronger supportive relationships with the nursing home. So this support doesn't just go away, that it's a continued support, and that they know that we're here to discuss complex cases as they arise. And as the admissions to the nursing homes, admissions to the acute hospital increase, it's more important now than ever to have a good communication line between both the acute setting and the residential care facility, so that the right person is in the right place at the right time.
And obviously that learning will support people who are listening. It's key, Clare. I suppose it's a great opportunity as a senior leader in gerontology nursing. I'm sure we have and will have a lot of your colleagues from older person services listening to this webinar. What message would you like to give to them? It's been a really tough time, just even listening to Brian, Deirdre, yourself today, but also from what we've heard ourselves from our own colleagues and in the media. What message would you like to give to your colleagues listening to this webinar today?
Well, I think our specific skill set as gerontological nurses has really shined through the most difficult circumstances that any of us will ever have to work through. And to be honest, I really couldn't be prouder of our profession right now. We do what we do because we're passionate about this element of patient care. And while it's been challenging and tough both physically and mentally, I really couldn't imagine doing anything else. I would like to remind everyone that our gerontological nursing community is strong and so determined. So we have to continue to support one another and ensure that we maintain that strength and determination that can get us through any of the challenging times ahead.
Clare, thank you. I think that the message says it all. Thank you very much. I would just like to briefly summarise what's been presented today from our panellists. I suppose we started with our national lead in older person services, Deirdre, and I think, Deirdre, you eloquently presented what has been happening nationally. You presented the viewpoint of your colleagues, their lived experiences, which, to be honest, listening to, it was extremely difficult. You presented stark statistics to really enable us to see the devastating impact that COVID has had on our older person sector in terms of, people being ill and deaths. I think the positive side of what you presented was what you did yourself in terms of your own initiatives nationally supporting services, and what your colleagues did in older person services has been absolutely admirable. And I really do think, from listening to you, I hope that people listening who are working in older person services can actually really hear the positivity from what you've presented, because there is fantastic work being done nationally. Deirdre, you also presented the responses that older person services have actually done, and again, they're excellent. And I think, in referring to the expert review, it is quite reassuring that the number of recommendations are there, and I suppose it's really up to us as nurses to really push to have those recommendations implemented as soon as possible. And your final message was actually so reassuring to colleagues as well. Brian, I think from a clinical perspective, it was great to hear your own role pre-COVID, because RMPs are key to the care, quality care, and how you actually took on the challenges of COVID to actually optimize your engagement with your own patient cohort as much as possible. Whilst you said yourself, some of the scepticism was that it was quite a simple task, but because you were using telephone as medium of communication, which was the right thing to do for that cohort, It certainly was a lot more than that. And I think you've presented that very clearly today in the planning that went into it, in what, your skills and how your skills were required to really engage the people that you're talking to at the end of the phone, be it a patient or be it a giver. I think the fact that you actually engaged patients in terms of feedback to make sure that what you were doing met their needs is so crucial, because sometimes we think we're doing great things, but unless the patients and their caregivers tell us the impact, well, then it's futile. So that's really reassuring. And I think people listening will definitely learn a lot from what you've learned yourself 6 months on from your experience. And then we heard from Clare, and I think, Clare, again, your role, it gives us a very good insight into swansea care and how things should look in terms of that, the crossover between acute community supporting each other to make the patient journey easier. Obviously, COVID had a massive impact on your role, Clare, and I think, really you rose to the challenge yourself and your colleagues. And just listening to you presenting on what you did was hugely beneficial to staff in the services you support, and to patients and residents. And I think what really struck me was your message at the end. It was really heartfelt, and I would really hope that everybody listening has really heard the through in terms of the key messages you've given. I would like to thank you all for taking the time not only to come today to present, but there was preparation in this, and it's been absolutely lovely working with you. I think you've really represented older person services really well, and it's admirable the work that you do. So thank you very much, and it's been a pleasure working with you. Okay, so in terms of where we're at with our webinar series, this was our second webinar. I'd like to thank all of our listeners, and I really hope you've enjoyed the webinar and taken a lot of learning from it, which is the theme of our webinar series, Sharing the Learning. Our next webinar will be on nursing and midwifery clinical leadership development during COVID-19, sharing the learning from midwifery services. We look forward to you joining us at that webinar.